Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, hello there, and a happy holiday season to all of you. We hope that you're enjoying the spirit of the year, no matter what. And today, Dr. Juliff, by the way, Vein Clinics of Hawaii is on 4 locations here in Hawaii, and they are a comprehensive vein clinic. And Dr. Juliff is the surgical manager of the offices, and he's the head guy. And what we do every week is we get together with the show and cover all the different things about vein disease. And some of the things are, pretty serious, and some of them are not. You've heard us talk about cosmetic things, and you've heard us talk about, deep vein thrombosis, which you see, the DVTs that you see on late night TV. Well, in between that, being very aggressive and everything is one thing when somebody's very, very ill. But what about some of you that are looking for a more conservative approach? Well, boy, today is your day. Dr. Juliff doesn't want to scare anybody today because today's topic is conservative therapy for vein disease. And isn't it sort of interesting, once somebody has been placed on the bell curve of where your disease is, if you even have one, that it give you a couple of different roads you can go by with regards to diagnosis and, more important, treatment. Yeah.
Absolutely. We talk a lot here about the interventional stuff that we do, because that's what we do day to day, and that is really what is needed for most people with advanced, moderately and severely advanced venous insufficiency. But there's another side to the treatment program for people, another option, and that is conservative therapy, where we don't really get into all the interventional stuff. We try conservative therapy in most people initially, and see if they're going to be okay with it. Most people, I would say, are not. But some people do choose that route, and some people we want to have stay in that conservative realm because it's better for them.
Yeah, and by the way, gang, I've had both. I mean, I'm a patient, not just the host of the program. One of these days, we'll bare my whole soul. We'll talk about my day at the doctor's office. But I think it's important because as the disease progresses, as we get older, and I've certainly experienced that, is that one of the things that you need to know is some stuff is not as aggressive or needing immediate surgery as others. So
right.
However, I'm the type of person, once I'm in the office, I want to say, okay, let's do the max, but you actually come up with the treatment program. Isn't it possible to say, all right, these little procedures are urgent. These we have to keep an eye on.
Yeah.
And isn't that unique to this disease?
No, I wouldn't say it's unique to this disease, because we approach a lot of different diseases in that fashion, especially if you're talking about surgical type remedies for whatever it is you're talking about. When we do interventional things, we're always thinking about the risk-benefit ratio. We don't want to do anything, and anything that we do interventionally, even if it's minimally invasive, which is what we do in the office, everything we do is very minimally invasive, but everything we do still has some risk attached to it. Now, albeit it's a very, very small risk. But,
and by the way, I want to tell you, when Doc says risk, I kind of smile because, we've all been watching these late night TV shows or any TV show, and you find out, oh my goodness, it's going to kill me. But I do know that a lot of that is based on needing to be overly protective, not just the doctor, but the insurance companies, the drug companies, and everything else. So when they say there's no risk involved here, they're not telling you the truth, because there always is a modicum of risk.
Right. If there's virtually nothing in medicine if you're treating the patient, and quite frankly, even with medication. I mean, even if you're only treating a patient with medication, there is some inherent risk to that. But from our standpoint, we want to make sure that what we're going to do to that patient, in whatever way, is going to benefit the patient, and it's going to be worth the risk that we're putting that patient through.
And don't some conditions require something more dramatic than others? I mean, I've had both kinds of. I've had cosmetic surgery, I've had regular surgery, and I've had some a little bit more serious. And each different slice of the pie has a different way you cut it and work on it.
Yeah.
Okay, so let's talk about that. And percentage wise, how many people need to get treated how many of the people that come into a vein doctor need to actually get treated sometime?
Right. I would say that probably just by virtue of the fact that people don't usually come into our office until they're having significant symptoms. So, by and large, most of the patients that we see would certainly warrant, just in general, intervention in one way or another. Now, some of those people are going to be too high risk. We were talking about risk. If in the very elderly and maybe in people who have multiple other medical problems, we might say to ourselves and to that patient, the risk of doing these procedures is just too high. Let's just do conservative therapy. But when you look at our patient demographic, some of them have had some form of therapy already.
Right. And that was my case, gang. When I first met Dr. Julev, I had been doing a similar program with a doctor who has since retired. And so obviously having the opportunity, but I didn't realize until there was a period of a couple of years that went by before my treatment and when I had the first procedure in your office.
Right.
And I probably should have had something in between then. And now that I noticed that I'm one of the people that needs to be re-examined a couple times a year just to keep a control on things. Sure. Isn't that ideally how a patient should be treated?
Yes. Yeah. I mean, definitely after we do interventional procedures on patient, we do want to keep track of them in the future. And as you said, usually every 6 to 12 months, we're going to try to do an ultrasound and see, make sure that everything's status quo, make sure there's nothing new coming up. But about 20% or so of our patients have had something done before. About half of those are patients who have maybe just had sclerotherapy, for one reason or another. About half of those have had interventional therapy. So those patients...
What's the difference, Doc, between sclerotherapy and intervention?
Well, when I say interventional, I mean the ablative type procedures that we do where we're putting a catheter into a vein or doing what we call microphlebectomy, which is getting rid of varicose veins. So it's the little more aggressive kind of things that we do, as opposed to just injection sclerotherapy.
Okay. Yeah.
And sclerotherapy has to do with injecting a medication into a vein. Sometimes we do that for just cosmesis. Sometimes we're just doing spider veins.
Yeah. But by the way, isn't that sort of interesting? If somebody expects that and it doesn't achieve the result, that means it wasn't aggressive enough?
That depends. Well, that kind of means a number of different things. Either, maybe we weren't aggressive enough for whatever reason. Their veins weren't responding the way they typically would, et cetera, et cetera. But there's a couple of different things that might go into that question. So 20% have already had something to do with vein disease, and they have an idea about what we're going to do. 20% or so have a friend or family member who have had vein care in the past, and they have a little bit of an idea about what we're going to do.
Well, they're in for a big treat though, because the new methodology, the needles, the chemicals, everything is so different than it was for grandma. Trust me.
Yeah. So half or a little over, I would say, probably have had no experience with vein care in any way before they come to us. And it's interesting. I think many people, or I would say probably most people, have a misconception about what we do.
I think it's a fear. I think a lot of people have a fear of what you do.
Well, they do. They do, because, whenever it's like going to the dentist, anytime there's a mystery about how much pain there's going to be involved, obviously they're not going to be.
That's not the fun meter, that's the pain meter.
Yeah.
But I can also say as a patient that I anticipated more pain since I started getting treatment by Dr. Juleff than I had before. But there's been changes. I mean, virtually, you have to really stay at pace. You spend a lot of your time with the new methods that are out, the new tests, the new medicines, the new everything.
Yeah, absolutely. Yeah, it's important. One of the things that attracted me to treating vein disease are all of the new kind of methods and devices that we have at our access now. And it's not only necessary, but it's fun keeping up with all that and utilizing them when we can. But I think people often have a misconception. One half of those people think that it's a lot simpler than what it really is. I think a lot of people come in and think, okay, well, gee, we're going to have a few injections and boom, 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 it's all done and everything's perfect.
It's not quite like that, but it's not too far removed from it.
Yeah, it's not. I mean, it's much easier than it used to be, but not quite that easy. Then, the other half of those people, I think, have an idea of it being even more complicated than what it really is.
Okay.
And like you said, we hear this from a lot of people. I think people come in and they have they don't really know what's going to happen, so there's some anxiety about that. But after they go through the process, I think most people are pleasantly surprised at how little discomfort and recovery and all that sort of stuff.
Yeah, and I'll tell you, I can swear to all of that. But I think what's also changed in me is my experience with the clinic. And by the way, you go to veinclinicshawaii.com and see where the locations are and what services are available and all of that stuff. But I still think that even me, I'm an alpha type guy. So once I realized somebody convinced me in the case, and I want to explain how it came to how people come to get diagnosed. Once I'm diagnosed and given the treatments, I want to say, let's do all of this stuff. So, and that's what's interesting to me is that I think that I've seen in your office, and I've heard this from other patients, the most complete initial impression. In other words, all of the things that you ask a new patient to do, and it's time consuming, but in the long run, doesn't it set up a pretty good platform about what you might recommend?
Yeah, absolutely. I mean, we when patients come into the office, the very first thing that we do is a pretty complete history and physical, and we've talked about our infamous iPad. Everybody gets a treat of playing with our iPad for about 20 minutes, and sometimes people get frustrated with that. But you're right. I mean, getting all of those historical details, not only about their vein history, but also about other medical problems and surgery and allergies. I mean, all of that is very, very important. So first thing we do is a very complete history and physical examination. We got to look at the legs and see what's going on. And then the next thing that we do is take a set of pictures, and that is kind of, a baseline. So that we can keep track of after treatment, how have things improved, or have they not, or whatever. But it's a good documentation tool to help us keep track of the effectiveness of our therapy.
There's another point in that, gang, and I tell you why. We're not going to do that this time because it takes a whole show. There's a chart showing the different stages of venous disease, and everybody fits on that chart somewhere. And I guess what you're talking about now is this initial consultation or examination is going to catapult somebody right into that chart where they belong. There's no mysteries.
No. After we do our initial history and physical, and especially after we do the ultrasound, we have all the information we need to kind of put them on that, timeline or vein progression kind of line, and yeah, as we've talked about before, that allows us to not only figure out what should be done for the patient, but also how urgently we might want to do it.
I'm going to think that sometimes if I go traveling, I want to take the Dr. Juleff thumb drive with me in case something happens somewhere else. And I know that that must be very, very difficult. I mean, you're operating on 4 islands. It must be very difficult because I do know that a tremendous amount of patients would get referred to an office when they're traveling and they don't have the comfort of their own doctor. Mm-hmm. Somebody says, "Oh, you got this thing on your leg. I want you to come to my vein clinic."
Right.
They might think, "Hey, I don't want the iPad. I just want you to stop that thing." How do you do that? I mean, because aren't those, quote, semi-emergencies in many cases?
They might be. You mean if our patients are elsewhere?
No. The opposite. Let's say mom comes over for Christmas.
Yeah.
And her leg starts acting up, and so daughter says, "You got to go to my doctor."
Well, luckily, we have sort of within the vein world, we have sort of a common language.
Yeah.
And part of that has to do with the classification methods that we have and all that sort of thing. So, if, for instance, if one of our patients were on the mainland and doing it in the opposite way, would we be very happy to send them, documentation?
Absolutely, perfect.
Oh, yeah, absolutely. And also, hopefully be involved in maybe a little bit of the decision making with respect to what should be done.
You know what I think is fascinating? You'll actually have people come to you from other places. I mean, it's like any professional that comes into your life, whether it's your tax guy, your dentist, your vein specialist, your cardiologist. They become, say, I think I better tell Doc about this.
Yeah.
I know I'm in Istanbul, but can I email you something? Can we take a look?
Sure. Yeah, and that's a nice part of this kind of practice because our patients really do become a part of our extended family, and it's nice maintaining those connections. But anyway, so after the history and physical, we take some pictures and then we measure legs and talk about stockings, and then after that, even before we've done the ultrasound, we sit down with the patient and we discuss what we think might be going on. At that point, we don't really know exactly what's going on, but we have a pretty good idea. And so we talk about some of the, what are the things that might put that person into a little higher risk bracket of developing venous insufficiency and vein problems. And as we've mentioned, genetics plays a huge role.
Does the when we talked about earlier the sclerotherapy as opposed to the more aggressive, don't you kind of know right away this is right up to this limit, this part of this person's concerns, that's the way we can treat that when we say conservative? That you're not thinking of going in like back in the day when it was in its infancy, when vein surgery was pretty invasive.
Yeah. I think we have at that point, even at the time of the initial visit, we have a pretty good idea about which direction we're going to go. Is this going to be something that's going to need absolutely interventional kind of treatment, and is that patient a good candidate for it? Or is the patient not so good and we're going to probably go a little more conservative? Or is that a patient that just needs conservative therapy, regardless of their overall medical status?
And most of the time here, just if you don't know this, and you can find this out at veinclinicsofhawaii.com, is we're talking mostly about the legs. I mean, there are lots of other things we'll talk about, but basically, and I'm guessing, Doc, that a lot of this stuff is, I may not be able to see it, but the minute you take a look at a leg, this person has that.
Yeah.
And now we have to corroborate it, do the ultrasound, do all the stuff. But you can see on the outside, even some serious conditions, can't you?
Oh, yeah. The outside is definitely a window to what's going on beneath. Yeah. We have a pretty good idea by what we see superficially as to how advanced their, venous insufficiency, if they have it, is.
There's this one little instrument that I'm fascinated with. It's a light that you put on your leg, and it actually looks inside. That's totally amazing, isn't it?
Yeah,
it's not an X-ray. It's not anything. It's just light.
Yeah, it transilluminates.
How deep can you see from one of those things?
Probably just several millimeters.
Yeah.
But and it's not really Well, it's showing you because it's projecting light into the subcutaneous tissue, and thereby
What you see backwards is what you
right. You're that it's sort of the veins become kind of backlit, I guess, and so it just makes it a lot easier for us to see veins that may not be varicose and elevated, but enlarged veins that are a little deeper to the skin, and it gives us a good idea about
what I liked about it is that my legs are kind of tan. And so, but once you put it on it, you see stuff that you would never see normally.
Right.
You think, wow, that's pretty neat.
Yeah. So then we talk about risk factors. We certainly ask about risk factors. There's a set of risk factors that go along with vein disease. Some of those are advancing age, female gender, people who work professionally in a job that requires them to stand for long periods of time.
And we've given a list of that. Yeah, you would be amazed how many of you don't understand exactly how much you do stand.
Yeah, sure. And then also sitting too. Those professions where people are sitting for long periods of time and not getting up and walking. Obesity, pregnancy. Prior vein disease, and by that I mean primarily things like DVT. If somebody's had a DVT in the past, do they have a higher risk for developing other vein functional problems? Yeah, they sure do. Immobility and lack of muscle use, as you might see it in various neurologic diseases, or in a patient who has had a stroke and they don't use their muscles as much. That gives them they have a little higher risk of developing venous insufficiency. But so the veins, just quickly kind of reviewing what veins do. I mean, veins bring blood back to the heart. And veins in our legs, therefore, should be consistently moving blood upward on its way back to the heart. And there's 3 different types of systems of veins that we talk about: superficial, deep, and perforators. They're all kind of interconnected. Luckily, most of the time, when people come in with venous insufficiency type symptoms, most of the time they have problems with their superficial venous system, which is good because that's
better than the problem way inside, right?
Yeah, that's a system that we can manipulate the most. What happens when veins fail? Well, basically, there's these tiny little one-way valves in the veins that keep the blood moving upward when they're working normally, and those valves can fail. When they fail, then the blood starts to move in the wrong direction, and it moves downward instead of upward.
Now, I am a real believer in that part of the explanation of Dr. Julev, because that's exactly me. Once you know that what happens is the blood that is supposed to be going back uphill to your heart is still going to go there, but a lot slower. In some cases, it pools up at the bottom and you get all swollen, and that's one of the big symptoms, isn't it?
Right.
Unexplained swelling.
Right, exactly.
Is it worse if you just get it in one leg?
Is it worse if it's?
I didn't say that. Isn't it possible that sometimes this you'll have a problem with one leg but not the other?
It's possible, definitely.
Yeah.
We see that occasionally. Most of the time, people, since it is a genetic problem, and your genetic makeup is influencing both of your legs, most of the time you're going to see it in both legs. However, sometimes we see it just in one leg and not the other, but very often we see it much more advanced in one leg than the other. They both might have a certain amount of venous insufficiency and venous reflux, but one leg is a lot further along in the timeline. Why that is, I'm not quite sure.
One thing, though, that I know, and I've talked to other patients, is sometimes that's when you happen to notice something more than the other. If you take a look at your 2 ankles when you're lying down, and one's bigger, you think, what's that all about?
Right.
That's why I asked the question when we first met, is why we measure. Well, because if you measure now and then you measure in a couple of months, you can really tell whether somebody is swollen or not swollen.
Sure, and keep track of it. We kind of follow people on our own timeline, and again, that's one of the measures of how well their treatment is improving them. So.
At what point in time, and this is interesting because we're talking about the direction of flow, when it becomes a problem. When the problem becomes greater, are there other symptoms other than just being swollen?
Yeah, some of the other symptoms that we typically see are achiness, heaviness, fatigue, muscle cramping, swelling, as you mentioned, restless leg syndrome, which we've talked about before, but a lot of people don't know exactly what that is. But it's when you have a hard time, or not a hard time, you have a propensity to kind of subconsciously be moving your legs and feet around. And a lot of people understand restless leg syndrome is something that wakes them up at night. Their legs are moving kind of indiscriminately, and that happens in a way that actually wakes them up. Well, that's kind of an extreme case, but what restless leg can be something as little as, like I mentioned, just having a hard time keeping your legs still, because when you don't have muscular activity, you have a propensity to have more pooling, because the muscular contraction helps blood flow upward. So that's what happens in restless leg. So a good amount of restless leg is due to venous insufficiency. Some of it is not.
I got to tell you something interesting, because I see more and more of these mattress commercials mirroring what you tell people is important all the time, and that's elevation. Right. In other words, now they've got it to a point where you don't have to elevate. Just press this. Up you go, down you go. Mom and dad can elevate at different levels. And isn't that something that it almost comes, automatically? I mean, my legs are sore, put them up.
Right.
I don't know if we need to be told that, but maybe for some of your patients, it needs to be scheduled rather than just every now and again. You should do it all the time.
Well, yeah, two things there. Number one, elevation is a part of conservative therapy.
Yeah,
we're going to talk about that in a second. But also that issue of, do you go home at the end of the day and elevate your legs because that makes your legs feel better? And yeah, people don't have to be told that.
Yeah,
They just
it's
find
almost
that
automatic.
It is automatic. And that's one of our parameters that we look at, one of those symptoms that we put a fair amount of importance on. If somebody comes in and says, oh yeah, at the end of the day my legs feel terrible, I elevate them and they feel better again, that's kind of a very strong sign of ongoing venous insufficiency.
And gang, those of you that are maybe newbies and don't know about what we're talking about, I got to tell you this, and this is pretty important. If you have these conditions, it almost is always indicative of something happens. And when it becomes a problem, Doc, is when it impacts somebody's ability to continue to earn a living or to enjoy something that they did that now causes them pain. And look at how many people, when they come to you, are almost at risk of not being able to keep their jobs because they can't perform like their bosses want them to or expect them to.
Right. Yeah, we hear that. We hear that, gee, I used to go to the gym all the time or run or exercise, and I can't do it anymore because of my legs. So it becomes not only a quality of life and also a professional, but also a general health problem.
Yeah, and everything else. How about when people say, well, I walk all the time. I walk a couple miles a day. When was the last time?
3 years
a couple years ago. You know? That doesn't help. I mean, you have to go forward accumulating stuff.
Yeah.
But that is also part of a conservative
walking
treatment, isn't it?
Sure. Yeah. So then as the valves fail, then blood becomes moving in a abnormal direction. We get this pooling, like we mentioned, and then if it goes on for a long time, you develop more and more of what we call venous hypertension, and that just means that there's increased pressure. Increased baseline pressure in the venous system constantly, and then that leads to secondary problems with the lower leg and the skin of the lower leg, and that's when we really start to get more concerned because those are sort of advanced signs. The discoloration of the skin that we see, and the thickening of the skin. And basically, all of that's happening because of the fact of this high pressure kind of system, and that pressure is making inflammatory molecules and other bad things go into the skin, and that's what creates the skin problems. And if left unchecked, that can actually go to chronic ulceration, skin breakdown, and all that sort of stuff that becomes very difficult to get healed unless you reverse that, venous reflux.
Yeah, and of course, if today's topic, gang, is conservative therapy for vein disease, when Doc's talking about some of those other things, it's no longer conservative. I mean, you've got to a point where there may or may not be conservative treatment for some of those cases that are well advanced.
Yeah, for sure. When we see those kind of patients, are we going to recommend conservative therapy? Well, no. Very, very rarely, unless the patient is just unable to undergo the procedures that we do. So we go through all that with the patient initially, and then we ultimately get to the ultrasound. And the ultrasound is a tremendous tool that we use every day of the week. And it really is a good tool to let us know exactly what's going on with vein function.
I also think that it's a great opportunity because, as I have learned, and every patient I've talked to learns, they feel like they're more part of the team that's dealing with the concern because they're explaining this stuff and then they can see it. And there's a big difference between well, we took an X-ray and here's what we think, because I can't read an X-ray,
right?
But I can sure watch that pulsing thing in there that happens to be my vein.
Yeah. It's fun. It's fun for the patient to watch the ultrasound being done, and Mike, our ultrasound tech, does a good job at explaining things and showing the pictures to patients, and yeah, you're right. It really does then start to make sense. We can talk about veins and valves and flow and all that sort of stuff all day long, but once they really see it going on inside their leg, it really kind of brings it home.
And by the way, if you wonder how you compare with others, that's what this chart is about, placing you somewhere in the bell curve of the disease. If you go to veinclinicsofhawaii.com, you're going to see some of these before and after, and you're going to see some of these symptoms that are explained. And some of them may look, wow, that's not like me. But in some respects, to some people say, wow, that is me. And that's why I was going to say, when you talk about, I do know that everybody's looking for a pill. And I've heard this from many, many patients. I'm sure you do all the time. Okay, that sounds good, but can I have a pill for that? Yeah. Isn't it kind of that there aren't a lot of oral medications that deal with vein disease?
There are not. There are a few, and we'll talk about that in a minute. But yeah, unfortunately, venous insufficiency is a mechanical problem. Again, the valve fails and the blood goes in the wrong direction. And
there's medicine for blood, and the blood's going through the veins. Yeah. But there's no medicine for the veins yet.
There's no medicine for the valve. No.
Yeah, the valve. That's what I meant.
But maybe someday we will have that. Probably a very, very long time. But it's a mechanical problem, and typically it needs a mechanical remedy. Even if we do conservative therapy, it's still primarily a mechanical remedy. And again, we'll talk about that in a second. But what I wanted to mention is the whole concept of conservative therapy. Some people will be treated long term with conservative therapy. Most of our patients are going to have at least a short course of conservative therapy, and that's part of that is just us going through the process of doing what we need to do and doing the evaluations and the ultrasounds, et cetera, but the insurance companies also, in general, require us to do some amount of conservative therapy alone before they allow us to go ahead with
I'm glad you say that, because obviously the insurance company is going to say an ounce of prevention. So if you can derail something before it becomes critical, that's the key to nab it at that point, right? But isn't there a time where you would respond to the insurance company and say, okay, we tried this and we tried that. This particular case needs this. Here's my request for coverage.
And that's exactly what happens. Medicare and all the insurance companies have their own period of time. Usually it's 8 or 12 weeks, so it's not a long time. But they do want us to show them that, conservative therapy is not either going to, handle the patient's symptoms adequately without doing interventional procedures, or number two, give the patient a chance to have, conservative therapy only, and to see if they're happy with that. Well, most people are not, because conservative therapy.
I can still see it. Or it still hurts.
But conservative therapy involves long-term use of things like compression stockings, and most most people, especially in Hawaii, aren't really all that excited about doing that type of thing.
I have not a confession, but a claim to fame, because I haven't seen Doc for about a month, and there has been, I think, one day in the month that I didn't wear my hose.
Good.
And it really makes a difference.
Oh, yeah.
Especially over a longer period of time. I'm telling you, if you sometimes on and sometimes off, just try it on for a whole week. You will notice a difference.
Yeah.
One of my thoughts was, wow, I have an ankle. Right. So that is, and yet that's just one of the many different options.
Right. Yeah. Right. Yeah. So what are the conservative ways that we treat venous insufficiency? And like we just mentioned, number one is compression stockings. It is definitely the mainstay of conservative therapy. There are other things that we try to get the patient to do, but maintaining consistent use of compression stockings is probably one of the most important things right up front, just as you just mentioned. What
if, though, you get to a patient will do that, and after a few months, there's obviously some relief, but is it enough? I mean, am I getting better? Am I getting worse? And what you have explained in the past is it doesn't make you better,
right?
But it maybe can help with the symptoms, or maybe help it from getting too much worse.
Yes and no. It definitely is going to work. Is definitely going to help with the symptoms.
Mm-hmm.
Yeah. Is it going to really prevent the progression of the venous insufficiency as time goes by? And again, if you have that genetic component for developing venous insufficiency, it's probably not going to eliminate your risk, completely. So, the question is, how completely do the stockings relieve the symptoms of any one patient? Are the stockings a realistic expectation of a therapeutic form for that particular patient?
Sure.
Are they going to be able to wear their stockings every day of the week? And again, unfortunately, most people aren't. But you mentioned what happens after several months. Then you come to this decision-making, point of is this enough relief? Number one. Number two, is it good enough for you to use consistently and persistently, indefinitely, or do you feel like you need something?
Yeah,
more?
that's really a good one, because a lot of people I do know that say I got to do it whether I want to or not because of my work. Yeah. My legs hurt. At least with these on, they don't. I can tell you one thing, and folks, you should pay attention to this because I'm a patient as well as the host. You go look at VeinClinicsHawaii.com and see some of the things we're talking about, this compression hose. I know it makes a difference. I mean, because sometimes, and if you haven't worn for a couple of days, you really know. Mm-hmm. But the problem is you got to get back on the horse.
Yeah.
And I do know a lot of people that will wean themselves off. Isn't that right? Once you've treated them, they say, well, my legs feel pretty good. I don't need these anymore. Right. Then they don't use them anymore.
Sure. And we try to get our patients to, utilize compression stockings even after we treat them. And typically what I say is, if you can even wear a moderate strength kind of stocking, just a knee high, it doesn't have to come all the way up. And if you do that just at work, that would be a tremendous. You will be serving yourself a tremendous benefit.
Well, most people work. You're talking 8 or 9 hours.
Sure. Yeah. So we call these stockings medical grade and graduated compression. And what does that mean? Well, the medical grade just I think refers to the extent of compression that's built into these stockings. And
does it vary a lot, by the way, the compression that you can buy?
It does vary substantially. Yeah, you can get something. We measure the compression of those stockings in millimeters of mercury. In millimeters of mercury is the same measure that we do like blood pressure.
Sure.
Your blood pressure is 120/8, for instance, and that's in millimeters of mercury. So we measure it in that sort of way, and the least amount of compression is down around 10-15.
Okay.
10 to 15 millimeters of mercury. And then they make stockings up to 40 to 50 millimeters of mercury. Now, I don't think I've ever used that strength. That's pretty tight. but we often will use 30-40 or 20-30. And
30-40 is pretty tight.
Is tight. Yeah, it's pretty tight. And we have used those in the past, primarily when patients are undergoing their procedures. And we feel it's a little more important to have a little more compression during that time. But for long-term use, a knee-high stocking, 20-30, I think is ideal, and it does give you enough support. So it would be considered medical grade.
I got to tell you, gang, they come in a lot of fashion colors, beige
or
black, and that's it. And so what I've done is, and the ones that I use, and you can explain why this is good for me and maybe others, is I have the knee-highs, but they don't have toes.
Right.
Okay, so it's an open-toed garment. But and by the way, it's a garment, not a sock. Yeah. Because if you just think it's a pair of socks, you're going to get blown away by the cost of them. Say, I can go down to so-and-so buy 15 pairs of socks for that price.
Right.
Well, yeah, but they don't have the compression. So what I do is I use the smallest one, I think the 20, 30, whatever it is I'm using, and cover it with a sock.
Yeah.
And there you can have your colors. And only you know. But I also know, because they're expensive, if you're going to walk around barefoot on them, you should wear another sock. Because it'll jam them up.
That probably protects them quite a bit.
It does,
a lot of people don't do that, but you're right. It would definitely protect them. People do that. The toe is open. I think there's a lot of people. Well, we can get them,
closed-toed, either way,
or
open.
Right. We stock primarily open toe, and that's because most people want the open toe.
Mm-hmm.
A lot of people don't like that compression on their toes.
Yeah.
It's a little uncomfortable. And then people, especially women, they want their toes out so that they can use slippers and sandals and stuff. So. That's one. But actually, if we can order, we don't stock a lot of different styles, but we can order different styles, and most of these companies are making very nice looking styles of stockings, and you can get sport socks.
It's changed, and I guess it's changed because even athletes that are not suffering with necessarily venous disease, they get a feeling of stamina or strength.
Yes.
Because not only are the stockings compressing your veins, but they're compressing your muscles too.
Right.
Making them be able to work a little harder, I think.
Yeah.
Or recover faster.
Yeah, recovery is the main thing there. Yeah. So anyway, so when should patients wear them? Well, again, primarily when they're going to be up and around walking, or especially in people who stand in one place for long periods of time while they're working. Those people definitely need compression stockings. Do you need to wear them to bed? Typically, no. Because you're lying flat and you don't need that additional help, for the blood moving upward. And do you absolutely need them when you exercise? Well, it's not going to hurt. I mean, there will be some benefit, but actually the benefit is not as great when you're exercising, because when you're exercising, your muscles are contracting a lot.
But what about the cases where, and I know this is in our notes anyway, but when that's just not quite enough?
Yeah, if the compression stocking isn't enough, then there are other forms of compression that we might need to go to, and typically this is a minimal number of people, but especially those people who are on the advanced side of the vein scale. Often we use this kind of stuff, but something called sequential compression devices, where you put your leg into a tube with Velcro, and it kind of holds your leg tightly, but that outer layer inflates, and usually we hook it up to a compressor, and so
that doesn't sound too mobile.
No, one of the drawbacks is that you have to lay down for 30, 45 minutes a day, and so that it's a little less appealing, but can be very, very helpful. Sometimes we use what's called multi-layer wraps in Uniboots, especially if they have skin problems, etc. So the second form of conservative therapy is elevation, as we mentioned before. And, a lot of people, you say elevation and they say, yeah.
That's a wide spectrum, isn't it?
Well, it is. And there's a right way to do it and there's a wrong way to do it. It definitely goes hand in hand with compression. And it can, when we're treating swelling, especially, which we often do, it really does make a difference. I mean, a lot of people think, oh yeah, well, I'm going to go home and I'm going to elevate my legs. But when you do it in the right way, it really can bring about a good, medical therapeutic response.
First thing I learned from you is make sure that your heels are above your heart.
Yeah.
When you're lying down or
Right.
when you're elevating.
Yeah.
That if you have your heels raised enough, then that's a good place to be.
Mm-hmm. Yeah.
I got to tell you, my wife she's much better at it than me. She can literally put her legs on a wall every now and again, get into bed and use the headboard and do that. And I know that some people do that and they don't need to do it anywhere near as long because it's so
Right.
so functional. I mean, it works very well when you get them up high.
Yes.
Yeah.
And I tell everybody what would be the ideal way to elevate your legs. Well, the most ideal way would be for you to hang by your feet from the ceiling.
Yeah, of course.
That would be the best.
Not many of us to do that.
No.
That's called the orangutan move.
yeah.
Not many of us can do that. Yeah.
Exactly.
Yeah.
So then where do we go from there? Well, in a realistic sort of way, the best way to elevate your legs is to lay flat.
Mm-hmm.
I tell people your body should be flat, either in bed or on a couch, and then you should put your legs up on 2 or 3 pillows.
Mm-hmm.
And that's the best way because, like you said, your legs, the area that you're trying to drain, have got to be above the level of your heart.
Yeah, because that's where you want it to go. You want it to flow down
Right,
that way.
exactly.
Yeah.
So then invariably the next thing that people will say is, well, I have a recliner, and recliners are not adequate. Because the fact
They look
that,
great.
it looks like you're doing something, and your legs are sort of up in the air, but your head is up. Your body is sort of still shaped like a V, and it's not a complete downhill roll for that fluid to go from your legs.
Let me ask you a couple quickies. Number one, are there ways that you can actually prescribe somebody a bed that will do that for you, help you do that? Number one. Number two, don't some of the medical supply places have wedges and things that are pretty good, but maybe not high enough?
Yeah.
Or maybe, it doesn't seem like it can be too high.
Yeah, no. I think the wedge is probably a much better way to go. Even a hospital bed.
Yeah.
When you look at a hospital bed, it doesn't elevate the legs, the way that it should. With the feet going up, it kind of, the knees go up.
The knees go up, yeah.
And that's another thing that people will say, well, I have a hospital bed at home. Well, yeah, unfortunately, that's not the best thing for you. So, actually, a wedge is a good idea because that will definitely keep your legs elevated, probably much more reliably than on pillows. And laying flat is a very important part of it too. So, and then as we have kind of alluded to before, it's best to avoid prolonged standing and sitting. But unfortunately, for so many people, especially if they work in a setting where they're on their feet, well, it's impractical. Just tell them stay off your feet.
I've got a guy that works for a construction company. And he's a traffic director. They now have to have traffic mitigation on all of these roadside jobs.
Yeah.
And he is 8 hours a day with the flags.
Right.
And no sit downs.
Worse scenario because not only is he on his feet all day long, but he's standing in one place.
And by the way, breathing carbon dioxide from these exhaust pipes all day long.
Not a healthy job. So anyway, the thing that you want to try to do, and I think in people who are in professions like that, we just try to encourage them to, number one, wear stockings at work. I mean, that's a tremendous benefit.
How about traveling, Doc? I mean, we used to be told, feel free to wander around the cabin.
Yeah.
That's over. Yeah.
Right.
Yeah.
Feel free to squirm in your chair for 3 hours. So we try to get people to take breaks. I mean, if they're in an office job and they're in front of a computer all day and you're sitting most of the day, then every hour or so get up, walk around, even if it's just a little bit. And likewise, in the scenario you just mentioned, even though you're on your feet all day long, if you're standing just in one place, then every hour kind of take a 5-minute break and walk around anywhere. So weight loss, and we've talked about that before. Obviously, that is a
less of a strain on your system. Too much weight contributes. Sure.
Right, definitely leads to worsening of venous insufficiency for sure. Obesity also brings about something that we've talked about before, lymphedema, and that kind of goes hand in hand with venous insufficiency. The other things are stopping smoking. Smoking does put people into a little higher risk bracket for venous insufficiency, and obviously always being on an exercise schedule if you can, which is beneficial for not only vein function but also a lot of other health issues. So let's talk a little bit about the medication. You mentioned medication before. And some of the things that you often come up in people with venous insufficiency, especially if they have swelling.
Yeah.
It's we often see people being prescribed Lasix or other water pills, and that might rid your body of a little bit of the excess fluid, but it's not like Lasix or another diuretic is going to say, "Gee, we're going to remove just the excess
interestingly
fluid
enough, you're right, because I've taken that stuff, and I can tell you that it is an equal opportunity taker. It takes it from everywhere, not just the area where you want it.
Right.
It's like spot therapy, right?
Yeah, so typically we don't. I mean, I virtually never prescribe Lasix for swelling because again, there are other remedies that are addressing the problem. But some people do, and it's in most cases it's not going to hurt you, but it's not going to be long-term good therapy. One of the medications that we do use a lot of is the non-steroidal anti-inflammatories like ibuprofen, and those are things like Advil and Aleve and that kind of thing. And those are medications that
they help with inflammation, don't they?
Yeah, they're anti-inflammatory, and so they're hopefully relieving some of the symptoms, and they're also helping with, I think, probably delaying or impeding the bad inflammatory things that go along with venous insufficiency. But again, it's not. It's kind of we're treating the symptoms and we're not really doing anything for the disease process. And then there's a number of naturopathic kind of things that people take. And getting back to what you mentioned before, unfortunately, there aren't a lot of medications that are really going to directly influence the progression of venous insufficiency. They may help the symptoms a little bit, but ultimately that the progression is going to continue, and at some point...
Yeah, you need a program. You need to get in. You need to see a professional.
Yeah.
And in addition, but some of these things I do know cause comfort.
Sure.
And people do feel like they're being proactive, that they're being, part of the experimentation. But I think that it takes a little more than Google to figure out what's going on with you, doesn't it?
Yeah. Sure. Yeah. And, so a couple of things that are out there right now are something called horse chestnut seed extract. That it relieves, again, the pain, fatigue, swelling, itching. It's said to address fluid retention a little bit. It's even said to limit the development of varicose veins, but again, it's not a staple.
What sort of a medication is it? Is it a fluid? Is it a liquid, or is it capsules? Or
no, it's a capsule. It's an extract from a seed, and it's said to thin blood and make vessels a little less leaky. There's a natural diuretic, and again, it's a natural kind of medication, and it may help transiently a little bit, but it probably isn't going to be a long-term remedy for the problem. There's something else called pycnogenol. That's another,
sounds like one of those late night things. Pycnogenol.
Yeah.
Okay.
It's also, it's an extract from a specific pine tree bark. And it's an antioxidant, anti-inflammatory. It's said to decrease the dilatation of the veins and improve symptoms. It improves the tone of the vein.
Sure.
And
if it makes you feel good, great.
Well, and that's just it. There's not a lot of scientific evidence that these type of naturopathic medications help or are going to reverse or alter the course of the venous insufficiency. But for what I tell people is that, hey, listen, if you've tried this stuff and if it seems to work for you, then fine, you should take it.
As long as you're working on some of the other problems too, like weight loss and no smoking and all of these kind of things.
Yeah, absolutely.
Pretty interesting. By the way, gang, this is just one tip of the iceberg. And if you'd like to know more about Dr. Juleff and Vein Clinics of Hawaii, we strongly suggest visiting the websites, because I think today, in just to sum it up in 30 seconds or less, there are plenty of options. Once you've identified where you are on this magic chart,
right,
then there's a lot of things you can sit down with your professional and get charted out so that you can take a swing at instead of just wondering what's going to go wrong next, how you can work on some of it.
Sure.
And so what we want you to do on that is, once again, go to the website. And I can guarantee you that you'll learn that, hey, once you get down there, boy, I'm not the only one with this. And like me, once you've tried this, particularly the compression stockings, I can't tell you enough. I get a gold star on my chart, by the way. I'm doing pretty well with that. We'll be back next time. In the meantime, if you got a question you want answered, I'd suggest you jump on the wagon. Call Vein Clinics of Hawaii. That's veinclinicsofhawaii.com. We'll see you next time. Have a great day.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.